need it where they need it, all right? And of course, in this sense, in the healthcare facility, but also the question on drugs and shortage and expensive and, you know, all those things. So then how can this contribute towards the achieving of universal health coverage? And of course, in this sense, on primary, you know, healthcare, because majority of the times people would say, yeah, we'll go to the hospital, we'll get this, Dr. prescribe these, but we don't get it, you know? So then how do we bridge that gap?
Actually, that's a good aspect to bring to this particular discussion, in the sense that whenever you hear stories of people saying, went to a hospital, but I didn't get care, did they not see a doctor? They definitely saw a doctor. They got tried and they went through the chain.
Okay.
What happened at the last step? They didn't find medication at the pharmacy. Okay. So, sikutibiwa leo, because they didn't get the medication. But how do we change the narrative and look at how do we make our healthcare systems work? By ensuring the medicines are available. And the medicines availability is something that is critical for us, because there's no care without the medicines, especially when you're unwell. Okay. So how do we make that matrix to work for us as citizens, as individuals? It starts from our own initial aspect of quantifying the products that we need. All right. You find in certain counties, we have antimalarials expiring, yet in other regions, antimalarials are needed and patients are not able to get them. And children are dying of lack of them. Yeah. So how do we ensure that actually, in terms of the initial moment of procuring and ensuring we have the medicines distributed from a KEMSA standpoint, being the national government, we understand what are the disease burdens that we're having, what are the medical recommendations based on the treatment guidelines to know that, by the way, if somebody is on having malaria, has been diagnosed and confirmed, they need to use AL, artemether-lumefantrine combination. That is what needs to be there. Then the hospitals in that region need to have it. That is missed at one step. And therefore, oftentimes you find the right medicine for clinic A, hospital A, is found in county B. Therefore, they don't get that mix. That is one gap. The other bit is because the people who are actually doing this quantification and all this supply management is somebody who, one, they don't have the medical background to even know, in terms of my supply of medicines, it has to be informed by the disease needs. Okay. So that this is what's going to treat these people. If I'm just a supply chain person, I'm moving products, I'm moving boxes. From A to B, their medicines are there. And oftentimes we capture them in good, glamorous pictures and stories. Yeah. Medicines worth 43 million distributed to Siaya County. This one to this county. But is it translating to impact? Do they need them? How many of them are expiring? Okay. You distributed 43 million, 15 are expired because nobody uses them. True. And those are gaps because we don't have the right qualified people to actually look at the dynamics of what the disease burdens are, link it to the medicine access, and then after looking at that medicine access, we now need to look at what are the other impediments to this access to these medications. All right. You go to a hospital, you don't get it, or probably the cost is substantively prohibitive. Why is that the case? Because in terms of financing of healthcare, oftentimes the cost of medicines is costed to be very high, but in reality it should not be that high because we have alternative medicines, from the branded to the generics that are available in the market. The question is, what do you consider to be treating you as a patient? You go to a hospital and you say, Mimi nipe original. And it's like the other one that is not the original is a fake drug. It's not. It's a generic, it has the same active ingredients and it's going to be cost effective for you. And therefore that happens. And then the other bits that are now coming to the cost of care that are going to be impediment. And currently when we're talking about UHC, from the second term for President Uhuru Kenyatta to the current discussion now and Kenya's Kenya Kwanza government, we're talking at UHC, NHIF as being a driver. Are we able to finance that care? And NHIF as a driver, we need to ask ourselves, how many of us go to hospitals and we're able to get the care we need because NHIF is catering for it? All right. If you're in employment and you probably have a private insurance, you're able to get the care you need. You're a civil servant, NHIF will cover almost everything for you. All right. How about an SME, an investor somewhere, or some employee at a particular level, or an individual paying their premiums? You pay 500 per month. When you're unwell, you're told in a quarter you can only spend 500 or so. It's already capped. And it's for consultation. So I'll go get consultation. After getting the consultation, you're told you need to do lab works. But unfortunately, NHIF does not cover for that. So will you pay out of pocket? Probably the test is 1,500. And I've been paying a whole year, 6,500 per month, and then I'm not able to get the care. Would I need to go, will I continue paying the following year? I don't have a need to, because of that lack of accountability in terms of, is it going to translate to care? It caters for my consultation, it will cater for the lab, and it will cater for the medications. If it doesn't cater for all these aspects, then I don't have an incentive. If I don't have an incentive, the financing doesn't come into place. And therefore, we are missing the point.
Absolutely. And there's a lot of push on the same, enroll, do this, do that. But then again, you know, once you enroll, the question is, do you get the services that you need and have, you know, the cover that is NHIF in this sense, you know, cater for the same. So then how do we handle this? Because majority of the people, and you hear a lot of people say, yeah, me lend hospital, I have my cover, my card, but nikabua, siko registered in that hospital, I have to go to where, and I'm sure you've heard, you know, this story. So then the whole question about financing and out-of-pocket, you know, expenses, how do we bridge this gap?
Insurance is about pulling funds together.
Okay.
And from the reports we read just the other month, is that the insurance penetration in Kenya, especially health, is fairly about 2%.
Okay.
2% of people. Now we need to ask ourselves, are we really taking up how many people are being enrolled into the scheme? So how much are we collecting so that when NHIF sits down and prepares the policy or schedule, you are able to be allocated more funds for a particular service.
Okay.
It's obvious if we have few people subscribing for the scheme, NHIF will not have enough funds to foot bills that come that they are presented to, because NHIF, again, it's not a business entity. It's a social, it's like social protection. So they're not into business to make profits.
Yeah.
So as a people, we need to take it as our personal responsibility to ensure that we have a medical cover.
All right.
Last week I was attending a funeral in my village at home, and my late aunt. So we were asking the people, okay, how many of you have got health cover here? Just NHIF, raise up your hand. No one.
Okay.
No one. From the hundreds of people who are there. Then I asked them another question. Do you know how much it costs to pay for your cover per year or maybe monthly? No. So yet again to begin teaching them slowly that it only costs you 500 shillings, which is when you milk your cow today and tomorrow and the other day, you sell that milk, it's already 500 shillings. You're able to pay for your monthly subscription.
Okay.
Why would you wait until when you get sick, then you sell the same cow that which will have paid for your premiums and then call for a harambe? So we need to get information out, educate the masses, take up insurance cover for those ones who can. Then the government should be able to cover the vulnerable and the poor who cannot be able to cover themselves. Okay.